They went to Chaitanya in 2006.
2000, sir, 2006. 2006 end, sir.
Oh, okay.
Okay.
Good evening and welcome to this another session of Arvind Retina Alumni webinar series. And today we have another very, very interesting and well-known speaker, Dr. Manoj Soman from Chaitanya Hospital in Trivandrum. He's not new to most of us in Arvind. He's a very, very popular person, more so because of his simple nature and down to the earth person. I know him as a postgraduate student, as a retina fellow, then as a medical officer. When he left Arvind, we felt he was not losing probably, but we felt that Arvind was losing a very, very good doctor from this
System.
faculty or this system. So, and today, Manoj has done so much of work, being a silent person, has done so much of academic work. He's always been interested, even when he was at Arvind, he was very heavily involved in the academic activities, in publishing. He has won a lot of awards. I wouldn't try to introduce, I'll ask Naresh to formally introduce him. But I just wanted to say that we have an excellent person, excellent doctor in Dr. Manoj, who's at Chaitanya today.
Thank you, sir. First, I would like to welcome Dr. Manoj. Actually, we were colleagues in early 2000. One person I always envy is Dr. Manoj. The reason is he's very popular than most of us because of his nature, number one. And number two, the thing which I have learned, but which I could never replicate in my life is 7:30 you'll start the work. You should see the case sheet, whatever the clarity he has written. 7:30 in the night, you'll be finishing. The last case sheet will have all the details which he has written for the first case sheet, which is impossible for me even today, actually. So it's I think, a great lesson to be learned from him by most of us. He has completed his undergraduation from Jipmer Pondicherry, and he has completed his post-graduation from Aravinda Hospital. Then he continued as a retina fellow and as a consultant here. And in fact, he was a very bright student, winning, clearing most of his examinations in UG with distinction, and he was awarded the Manikaswamy Endowment Prize. And he was an observer in with Dr. Abramson and Dr. Lawrence Yanusi, Julia Haller in US way back in 2004. One thing he has not mentioned in his biodata which he has sent is, I think he has won all possible awards for the retina in Kerala State Ophthalmic Society, right from the best paper to the poster to video to everything he has won. And he has got many best paper awards in AOIs also in medical and surgical retina. And he is on the community front, was involved in Project Retina Trinetra at WDF sponsored program run by Chaitanya Eye Foundation, and he has got over 20, he has trained over 20 medical fellows, including 5 medical and surgical retina trainees in his place. So we are very delighted to have Dr. Manoj, and this particular topic, because it's always a very difficult question when the patient asks us how many injections, when to stop, where to start. So that is going to be addressed by Dr. Manoj. Thank you, Dr. Manoj, for accepting our invitation. Over to you.
Thank you, Dr. Naresh, and thank you, Kim sir. Thank you, Kim sir, and thank you, Dr. Naresh, for that wonderful introduction I think that was more than that was. I think it was said more than what I really am. But anyway, let me start with my respects to Dr. V. I was very fortunate to have spent some time with him when he was in Pondicherry, just before he left us, and it was a great experience and something that I will never forget in my life, because I believe that I'm a better human being because of the interaction with him during that period, and it has always helped me to stay grounded all these years. To my teachers, PN sir, I think I was one of his last fellows. Kim sir, he's taught me everything in retina that I'm doing now. I learned all my vitrectomies from him. It is really a great honor, sir, to have worked under you, to have learned from you. Now when I always used to think that I was his favorite fellow, and yeah, I think when the next batch came, I'm sure that somebody would have thought the same thing. I mean, that's the kind of relationship we had with his fellows. It is really a great honor, sir, to have trained under you. GN Madam, RDS sir, all these have all my teachers have inspired me to be what I am. Dr. Mamta, who was a medical officer at the time when I did my fellowship, I remember her, and of course Dr. Shukla, and he had really put us through the grind during our fellowship days. And it was during that time that he started, his publication spree, and we were all involved in bits and pieces. And I think that a part of it has stuck on with us. So, and some of us are very active, even in the academic side till today. And then I actually had a company of great friends. Dr. Naresh was there with me at that time. We shared the same passion. Anand Rajendran, Rodney, and a good group. We all shared the same passion, and I think that has carried us forward. Now, getting into the talk proper, I've titled my talk "Optimizing Anti-Vegf Therapy Outcomes in Choroidal Neovascularization." And most of the statements that I make today are my personal views and my interpretation of the literature. Now, choroidal neovascularization is all about AMD. So therefore, in today's talk, I will be discussing these four heads, try and simplify the AMD trial data for you, discuss how to choose the right drug and strategy, discuss about knowledge about the potential after effects of therapy, and also discuss the role of imaging biomarkers, which could be used as a guide to treatment. Now, as Rick Spade put in his editorial in 2017, choroidal neovascularization is probably not a disease, but a compensatory perfusion mechanism secondary to a chorioacupillary disease. And the commonest chorioacupillary disease in question is age-related macular degeneration. The prevalence of late AMD is in the range of around that these patients require. And some of these factors have led physicians to explore different regimens for anti-VEGF therapy. And therefore, we had varied approaches to anti-VEGF dosing. We had monthly dosing, we had a bi-monthly dosing, we then had a quarterly dosing, we had a PRN schedule, we had the treat and extend protocols, the wait and extend protocol, observe and plan. So we have a lot of protocols that have found anti-VEGF therapy to be useful in patients with choroidal neovascularization. And if you look at most of these studies, what they've said is all these studies have shown a very good visual improvement. The visual gain is approximately in the line of around 8 letters in a year's time. This is how these studies have done. Now, if you have to simplify all the studies, the monthly regimens, if you look at the monthly regimens, you could consider them as a standard of care because they had excellent results. they had the best visual gains. But the problem with these regimens were that you require more injections, and in real life it is really a costly affair because we are all aware of the cost of drugs. Also, there is a possible risk of certain complications, and therefore it is not feasible in our population. So, a more practical approach would be a PRN regime, which is good, but it still requires, ideally, it still requires periodic monthly follow-ups. These regimens involve lesser injections, so in real life, it turns out to be less costly, and of course, there is less vision gain in this regimen, and therefore, this could mean suboptimal treatment. The trade-off now, what we have now, is a treat and extend regimen, which is reasonable and is getting quite popular these days. It has got good anatomical and visual gains and lesser visits, which may improve the patient compliance better. So this is overall, putting in a nutshell all the trials and the recommendations. Now, from the patient's perspective, the frequent treatment and monitoring requirements place a heavy burden on the patients, and their lives are preoccupied by frequent clinical visits. And this could be one of the reasons for poor compliance. And poor compliance means poor outcomes. So the need of the hour is to strategize well, to decide what is the right drug that has to be used and the right strategy that you need to adopt. Now, if you look at the anti-VEGF molecules by itself, we all know that aflibercept is a more superior molecule because of its pan-VEGF blockage, wider action, and its higher affinity to the VEGF receptors. But now we have brolucizumab, which has recently been launched, which has shown to be even better than aflibercept in treating these patients. Now, Lucentis remains the most widely trialed anti-VEGF agents. We have a host of trials which have vouched for the efficacy as well as safety of this molecule in choroidal neovascularization. The CAT, IVAN, and the GEFL trials reported that Avastin had equal effects when compared to Lucentis, and that it was not non-inferior. And then we had the VIEW trials, which was a comparison between Lucentis and Eylea, and again it showed that Eylea was non-inferior to Lucentis, if not better. And very recently we had the Hawk and Harrier trial, where there is a comparison between brolucizumab with aflibercept, and they have shown that this new molecule has better thickness reduction, better drying of all the types of fluid, and ability to maintain 12-weekly follow-ups. So this is overall, about the drugs that we have. So the question is now, how do I decide? So in practice, these are the things that I look at before I decide which is the anti-VEGF molecule that I would choose, or which is the strategy that I would choose. I look at the type of CNVM, the size of the CNVM, the baseline visual acuity, whether the patient is a treatment-naive patient or is it a treated and earlier treated CNVM, is it a resistant CNVM, is a CNVM associated with large PEDs, is there a partial scarring to the process, is it a secondary CNVM? I would also look at affordability issues, the risk of atrophy, systemic considerations, and explore if there is a scope of combination therapy. Now, how do we classify CNVMs now? We would classify them as type 1 CNVM, when the CNVM is all lying under the retinal pigment epithelium. This is what we used to call it as occult CNVMs before. And then we have type 2 CNVMs, where the CNVM is lying on top of the retinal pigment epithelium, above the retinal pigment epithelium, which we used to call the classic. And the type 3 or intraretinal neovascularization, which we used to call the retinal angiomatous proliferance. And one form of type 1 CNVM that needs specific mention is the type 1 aneurysmal membrane, which is very popularly called as polypoidal choroidal vasculopathy. Now let us see this example. This is a patient with a small classic CNVM. The visual acuity was 618, and this patient came with a sudden defective vision. We put him on a PRN schedule. He just received 3 injections of Lucentis, and as you can see here, this is at 4 months, showing a really dry fovea, and this is at the end of 1 year with PRN visits. The patient required no further injections, and the patient is maintaining a good vision. So what we learned from this case is that when you have small CNVMs, and especially when they are classic CNVMs, these patients they do not require multiple injections. They may do well with a lesser number of injections. And any of these injections, that we have just discussed, is good enough. Avastin or Lucentis, any of these are good enough in these small CNVMs. If you look at the analysis from the 5 landmark trials, they have shown that the most important risk factor for predicting good visual outcomes was the lesion size. So whenever you had a lesion size of less than 1 risk area, then these eyes had a better outcome. The probability of these eyes, retaining 20, 40 or better was very high. So size of the CNVM is something that I would consider before starting therapy. The anatomical classification of CNVM is also important. And this is a very important analysis from a treat and extend protocol. So what this clearly shows is that the type 1 CNVMs are the best in terms of final visual outcomes. As you can see, that though initially there is they are slow to gain vision, but they finally end up with reasonable visual gains. Whereas the type 2 CNVMs, though they have an initially very good outcomes, they can actually end up with visual loss little later on, and this is exactly what the CAT sub-analysis showed. Classic CNVMs are more likely to develop scarring at the end of 2 years. And type 3 CNVMs are the ones that did badly with anti-VEGF therapy. They're slow gainers, and they tend to lose vision down the lane. So looking at the type of CNVM also helps us to plan the therapy. Now, this is a patient who had an occult leakage, and you have a plaque on ICG. This is a fibrovascular PED with SRF and a subtle loss of vision. The patient was treated with Lucentis, and this was again a PRN schedule. PRN is the most common schedule that we practice. After a loading dose, we put the patient on a PRN schedule where we follow up the patient on a monthly basis, or try to follow at least on a monthly basis, assess recurrence of fluid, and re-inject. So this at 6 months after PRN Lucentis, the patient doing fairly well in terms of anatomical improvement. But this is at the end of 12 months, 6 PRN Lucentis and 14 visits. Most of our patients now, they come for an examination and then they come another day for the injection. So this patient ended up coming 14 times in a period of 12 months, and he still has activity as like what he started off. So this is the problem with occult or type 1 CNVMs. These patients often require long-term treatments. Their visual acuities may be good, but then they require long-term treatment. And what we have realized along the years is that PRN often is not enough. Treat and extend may be a better option to treat these patients. And we have data from the CAT trial which has shown that PRN eyes are not as good as monthly injections in terms of visual acuity gain. But treat and extend, this is from the TREX data, the treat and extend arms are almost comparable with the monthly injections. So treat and extend seems to be a better option in treating these patients. Now, if you look at the Harbor data, which is the PR, because we most of us follow the PRN data, I picked up this study. This is the Harbor study, which is again a PRN-based study involving ranibizumab, and this talked about baseline predictors of visual acuity. Now, if you look at the baseline predictors, so they look at a host of factors, from demographic profile to all the features on the OCT and angiographic features. And they came out with 3 important conclusions. They found that when the baseline visual acuity, these are 3 important factors that were related to the final visual acuity: baseline visual acuity, age, and size of lesion, amongst all the variables. So when the baseline visual acuity was 636 or worse, that these patients had a better visual gain. When the age was younger than 73 years, and then the visual gain was better. And when the lesion was smaller, these patients ended up with the better visual gains. They also found that subretinal fluid was an important variable, not only in terms of final visual acuity, but also in terms of treatment frequency. This seems to be the only, among the multivariate analysis that they showed, this was the only variable that actually influenced the number of injections that patients receive. So the question is, do we really treat patients with AMD based on fluid subtypes? Do we really need to look at fluid very carefully? So the answer is yes and also no. Now let us look at some of the fluid components. What is the importance of intraretinal fluid in neovascular AMD? Is it as relevant as the subretinal fluid? Now we have the data from the CAT trial, which has clearly shown that when eyes even at baseline, eyes with intraretinal fluid had worse visual acuity than eyes without intraretinal fluid, and also eyes with foveal intraretinal fluid had worse visual acuity than an extrafoveal intraretinal fluid. And the Excite, Mont Blanc, and the View trials have shown that the presence of intraretinal fluid at baseline is associated with a negative impact on the best-corrected visual acuity. And not only that, they also show that residual fluid and new fluid that happens during therapy are also associated with worse visual outcomes. So intraretinal fluid is a very important component. Now, what about subretinal fluid? We all have been treating subretinal fluid all these years. How about baseline subretinal fluid, and what is the importance of persistent or recurrent subretinal fluid that we encounter during treatment? Now, with regard to baseline subretinal fluid, what is exciting is these studies, Excite, Harbor, and View studies have shown that the presence of subretinal fluid at baseline and even residual subretinal fluid were associated with either better or stable visual outcomes. So it was not as bad as intraretinal fluid. In fact, a fluid study, which we are all aware of, had talked about tolerating 200 up to 200 microns of fluid. But however, there are also other data which suggest that recurrence of subretinal fluid during the maintenance phase could have a negative impact on the visual function. This is an interesting study which looked at new SRF versus persistent SRF. Now, when you have new SRF, when you follow up a patient, then these patients are more likely to have visual loss than persistent SRFs. But if a patient who has persistent SRF due to some reason starts dropping vision, then this patient would have a lower chance of recovery. This is what this study concluded. So both new and persistent SRF seems to be important. Now the fluid study is much harped, but then there are a lot of issues with the fluid study, tolerating 200 microns of fluid. A little controversial, but there are certain flaws in the sense. Now, if you look at the intensive versus less intensive arm, there is not much difference. There's only just a difference of one injection. The overall the visual acuity gains also in this treat and extend protocol was not as promising as the previous treat and extend study. So there seemed to be something missing in this study. Also, they seem to tolerate intraretinal fluid. Degenerative cysts were potentially tolerated. This happened. They started this step halfway through the study. So there are some issues with the fluid study. However, what the study generally does denote is that you could tolerate some amount of subretinal fluid. Now, what about sub-RPE fluid? Sub-RPE fluids, have been associated with poor visual outcomes in many studies. Now, the question is it an isolated biomarker by itself? Now, if you look at the data, the Excite, Harbor, and Mont Blanc studies clearly looked at the effect of PED on the final visual outcome in patients receiving anti-Vegf therapy, and they found that it did not. So sub-RPE fluid did not influence the final visual acuity. However, if you look at the View studies, which is primarily aflibercept, they showed that when there is baseline PED with intraretinal fluid, when you have two features, sub-RPE fluid with intraretinal fluid, then these patients had a poor visual gain. And they also showed that these are the eyes, when they switched from fixed to variable dosing, they went on to have poor outcomes. And also these are the eyes that required more number of injections. So it does seem to matter, not as an isolated biomarker, but with concurrent fluid, this could be considered as a biomarker of activity. Recently, the Hawk and Harrier study also clearly mentions that lower levels of any type of fluid, be it intraretinal, subretinal, or sub-RPE fluid, was associated with a better visual outcome regardless of the other fluids. So it means that all these fluids are important. So the current evolving understanding of neovascular treatment, AMD treatment, is that fluid of the OCT in any space is an indication of active disease for which anti-Vegf therapy may be warranted. It's not just subretinal fluid; it is more of intraretinal fluid, and also sub-RPE fluid is important. Even though fluid resolution correlates to visual improvement, we have also seen in practice that the magnitude of that improvement is patient-specific. It seems to vary between patients. Why does that happen? So this is something that has come up recently. Do fluctuations in the retinal thickness or fluid, does it have an effect on the visual outcome? This is an interesting study, that is analysis that has come out from the Hawk and Harrier studies. What they did is they looked at the degree of recurrent fluids, the
Manoj,
variations of fluid, and they
Manoj,
divided patients.
sorry, your sharing has stopped or something. Your slide sharing.
Yes, sir. Slide sharing has stopped.
Oh, it's coming. Now it's seen. Continue. Sorry.
Yeah. Yes, sir.
Continue.
Yes, sir. So they looked at SRF fluid variations during treatment. So they categorized patients into four groups. One group having a large variation of fluid, and one group having very minimal variations. And what they showed is that when patients had large fluid variations during follow-up, these patients ended up with worse visual acuity when compared to eyes which had less variations, which had better visual acuity. And they also did the same analysis in the cat and IVN trial, and they found similar effects. So irrespective of whatever agent that we use, whether it's Brodizumab or Eylea, or whether it's Lucentis or Avastin, when you have fluid variations, especially higher variations in the fluid during follow-up, then these patients tend to have poor visual outcomes. This is a better looking slide which tells us clearly that when you have variations which are less, then these patients end up with better gains, and when you have variations which are more, then these patients end up with poor visual acuity. Also, this study showed that patients with less variations had fewer visits when compared to those with larger variations, where these patients required multiple visits. So the fact is that persistent fluid leads to bad outcomes. Now even the PIRE study earlier on showed us that after the initial loading dose, there was a phase where there was a group of patients where there was no fluid. These patients ended up with good visual acuity, whereas those with fluid ended up with poor visual acuity. The Hawk and Harrier trials also showed that early fluid-free states ended up with good visual acuity when compared to delayed fluid-free states, which ended up with poor visual acuity. Now, if you have to look at which is the best drying agent, that amongst the agents, it used to be Eylea till recently. Now that we have Brodizumab, which it seems to be a better drying agent amongst all the anti-VEGF molecules. But one thing that we have to keep in mind is this phenomenon. Sometimes you see these PEDs and they settle. You see these small hyperreflectivity that you see under the retinal pigment epithelium, under the neovascular complex. Now, this is not sub-RPE fluid. This is choroidal clefts. So this also is important. These are some examples of choroidal clefts. And the importance of choroidal cleft is that it is seen in around 8 to 10% of neovascular AMDs. There are basically two types of clefts. Clefts that happen a little early, less than 6 months, and clefts that happen beyond 6 months. And if a cleft happens before 6 months, then these patients have a poor visual outcome, and they may be poor responders to anti-VEGF therapy compared to those where the clefts happen beyond 6 months. The next consideration that I would keep in mind is try and find out if the patient which has been is treatment naive or is previously treated. Now, if it is a previously treated patient with a good response, whatever be the regimen, whatever be the drug that he's using, I would actually continue with the same regimen because it makes sense. But when you have a previously treated patient with a poor response, then I would try and see if the treatment regimen was correct. Was a patient compliance good in this patient? If it is so, then I would be thinking in terms of changing the anti-VEGF agent. So this is a situation where I would switch to a different anti-VEGF agent. Now let us see this example. This is a patient with a mixed CNV. You have a type 1 disease activity here, and you have the SHRM and the type 2 disease activity here above the retinal pigment epithelium. So both classic and occult activity. And this is at baseline. The patient was treated on a PRN basis, and this is at the end of 13 months. As you can see, the patient received 8 ranibizumab, but the patient is still not doing well. What is also happening is this presence of the subretinal fibrosis that has started. So at this point, we decided to switch to aflibercept, And this is after aflibercept. As you can see, after 3 years aflibercept and 7 months post-loading dose, there is no fluid, but already the damage is done. There is a lot of subretinal fibrosis. So switch needs to be done at the right time. The time of switch is important. When there is unresponsiveness, you need to switch therapy. Aflibercept seems to be a better drug. When you need to consider switch. Now, defining anti-VEGF response is something that is very controversial. We are not sure when should you call it a good responder and or bad responder. This is an interesting study which really talks about it. When you have a response after 3 loading injections, you could call this as a primary response. And if the response happens a little later, like around 6 months after the loading dose, then you could call this as a secondary response. There are some criteria that are put forth to define what a good response is and what a bad response is. This is based on morphological and functional criteria. So if you look at the mechanisms contributing to reduced efficacy, there are a lot of mechanisms, but I think the most important factor that is responsible for reduced efficacy or poor response to anti-VEGF therapy is less frequent injections in our practice. So this is the most important thing that we need to keep in mind. Either it's less frequent treatment or a poorly compliant, especially a poorly compliant patient, may be the reason for poor response to anti-VEGF therapy. Now, switching between anti-VEGF therapy, this is a survey article which talks about this. They conclude that there is no evidence for a generalized superiority of one drug over the other. But they also agree that there may be a subset of patients with a particular genetic or pharmacodynamic characteristics for whom a drug switch may be beneficial. And they also say that it is not possible to provide recommendations regarding a definitive time period or a clinical parameter on the basis of which the switch has to be done. But in practice, this is something that I do after a loading dose of 3 injections. I look at the response, and if I feel that the patient is not responded adequately, then I would start considering switch. At least I'll talk to the patient about the need for switching therapy. And by around 6 months of adequate therapy, good compliance, patient is not responding well, I would definitely do a switch by this time. I would look at the onset of detrimental events like presence of RP atrophy or subretinal fibrosis. So if you see these things, I would definitely consider it as poorly responding and switch. This is a patient with a PED again. You see this portion of the PED is serious. Here you see PED with internal reflectivity. Basically, the knuckle CNVM, but on the ICG you see a polyp with the late plug of the branching vascular network. So this is a PCV patient. And this is at baseline. The patient was put on monotherapy. Lucentis again on a PRN schedule. This is at 4 months. This is at 12 months. After 6 injections, the patient still having subretinal fluid. So this patient, at this point of time, we switched him to aflibercept, and after 3 loading doses of aflibercept and through a treat and extend regimen, just receiving 1 injection, the patient through month 26 maintaining a relatively dry fovea. So what we learned from this is that in PCV eyes, aflibercept may be a great drug, but what we need to understand that a PRN may not be enough. We may have to think of a strategy like treat and extend. And this is exactly what the Planet study showed. The Planet study showed that the treat and extend protocol using aflibercept may be a better option than ranibizumab in treating patients with PCV, especially if we are thinking in terms of monotherapy. This is a one-eyed patient, a scarred CNVM in one eye, and the other eye, there was a PED to start with some occult activity. And this is the OCT, and when we started treating the patient, the visual acuity is 624. And as you can see through 1 year of follow-up, the visual acuity is kept dropping, the PED is never flattened, the fluids were still persistent. The visual acuity dropped to 5/60 at this point of time. You can see here on the IR image, the PEDs being huge. The patient was poorly responding to the PRN ranibizumab, and at this point of time, we switched him to aflibercept. The single injection, as you can see here, the visual acuity comes back to 636. With a few more injections, the visual acuity is maintained at 612, and patient has fewer disease activities after that. So, in resistant cases and in eyes with large PEDs, especially those with serious PEDs, aflibercept is a good option. Because if you look at the trials, the major trials have not really looked at eyes with large PEDs. Only the Harbour study looked at least a part of this, and then they however did not find PEDs a risk factor, but there is no data on large PEDs. The Pronto study earlier had looked at this phenomenon, and they have highlighted the resistance of PEDs to ranibizumab therapy, especially the PRN schedule. So therefore, in these eyes with large PEDs, PRN schedule is probably not enough. Ranibizumab is probably not enough. This is an eye where aflibercept is probably going to work, and there are a lot of case reports which have really shown that aflibercept is effective in these eyes. This is a similar situation. This is a large CNVM that you see here, and a large occult activity. And this is the OCT. This is what is called as multi-layered PED. Now, multi-layered PEDs, they remain huge. They have multiple layers forming as the disease progresses. But these eyes, they maintain relatively good visual acuities, and they're kind of resistant to routine anti-VEGF therapy. This is a patient who was receiving Lucentis. He has switched over to aflibercept. Now, even with aflibercept, as you can see here, the PEDs have slightly flattened down, but the multi-layering definitely, it remains there. So this is another group of patients now where aflibercept may be a better option to treat. This is a patient who was written off by his treating physician because they thought that it's predominantly a scar. But when we saw the patient, a lot of fluid, and this is the only eye of the patient, and therefore we thought we would give him the benefit of anti-VEGF therapy. And following 4 Razumab injections, Razumab is a biosimilar of ranibizumab. This patient improved visual acuity to 624. So don't write off these eyes, especially when you see one-eyed patients in partially scarred CNMs. In select cases, not in all cases, in select cases, you could use any of the anti-VEGF therapy. You don't have to follow any particular strategy. A loose PRN strategy is good enough, but don't lose heart. These eyes may achieve some visual gains. This is a myopic CNVM, and this was treated with just 2 injections of Avastin and showed good resolution. So we have all seen this type of situations. So we have the Radiance and the Repair trials which have shown the efficacy of ranibizumab over PDT in patients with myopic CNVMs, and we had a mirror study which supported the role of aflibercept in these eyes. So in other secondary CNVMs also there are studies, especially the Minerva trial, which has shown that both Avastin as well as ranibizumab seems to be effective. Most of these trials used a PRN kind of schedule. So in these secondary CNVMs, a PRN schedule is good enough, and any of these agents, Avastin or Lucentis, is good enough. Again, in inflammatory CNVM, this is a pretty large series from our country. Again, here they concluded that both these agents, ranibizumab and Avastin and bevacizumab, are effective on a PRN schedule in these eyes. This is an interesting patient that we saw. It presented initially with the bilateral vitaliform like deposits, and this is on the structural OCT. You see a small PED there. Some of these eyes, even the AVD eyes can have PEDs. We thought these are the vitaliform deposits. This is there's also pachychoroid in this patient. And when we did an multimodal imaging, we could see this definitely on the fundus autofluorescence, the pattern appearance. But on the FA-ICG, we could not pick up a membrane, so we decided not to treat. We just observed the patient, and this is what happened over a period of 1 year. We saw that the PEDs gradually flattened. You can see the migration of all these vitaliform deposits to the center, and finally, it kind of got absorbed without any treatment. So this has to be kept in mind. But what is interesting is in the other eye, when we looked at the other eye, this eye also had some vitaliform deposits. And on the OCT, we found a small localized DLS here, the double layer sign here. There's no evidence of fluid. So when we looked at OCTA, the Opta revealed the presence of a, sorry. Sorry, I think yeah, sorry. So the Opta revealed the presence of a neovascular net in the avascular layer, and also
Manoj,
on the
sharing of your slides discontinued
yeah, and
suddenly.
I'll just get it back. 1 second.
Yeah.
Is my slide seen now? Naresh,
Yeah,
can
yeah,
you see
it's
my
seen now.
slides now?
Yes.
Okay. So this patient we picked up a neovascular network on the Opta, but on the structural OCT there is no fluid. So this is I think it's gone again.
Yeah. Again, it's gone.
என்ன பண்ணணும்ப்பா? ஸ்கிரீன் ஷேரிங் மட்டும் கொடுத்தா போதுமா?
Yeah, it's now seen.
ஏன் இதுல வரல?
Okay. So this is a non-exudative CNVM that we saw, and we just followed up the patient because there is no fluid on the OCT. But 17 months later, no, the patient started presenting as an exudative CNVM. So non-exudative CNVM is something that we need to keep in mind, especially when you see patients intermediate roots, and sometimes doing an OCT angiography may pick up these non-exudative CNVMs. And this is the Opta at that point of time showing a larger neovascular element under the retinal pigment epithelium. So what is the importance of non-exudative CNVM? Some of them actually progress to exudative CNVM. This is a recent analysis which looked at progression of non-exudative CNVMs, and they showed that nearly 20% of these eyes progressed over a period of 12 months. So Opta or OCT angiography is a very useful tool. It's a useful tool that helps us to understand the nature of the new vessels in these membranes, in these choroidal neovascular networks. So these are some of the described networks that are described. Active CNVMs can have a medusa head appearance where you have a central feeder vessel with profuse capillaries around it, or you could have a C-fan-like appearance, or you could have an indistinct network. And when you don't see multiple capillaries, then you call this as a pruned network, which represents an inactive disease. Recently, we did an analysis. We tried to compare Opta versus ICGA. And what we realized, this is in real life situation, what we realized is that all the well-defined patterns are very similar on the ICGA and Opta. But all these ill-defined patterns, the filamentous and ill-defined, which we see on the ICGA, if you do an Opta, sometimes you can pick up a well-defined membrane. So Opta seems to be superior to ICGA. We picked up nearly 15% of these lesions having a well-defined pattern on Opta. We also looked at whether these patterns, did it really make any difference in terms of management? So we found that all these patterns showed a decrease with anti-Vegf therapy, except one pattern which we coined a new term for this. We called this as a fishnet pattern. This alone showed worsening while on anti-Vegf therapy. So Opta is a very good tool because it demonstrates the decrease in the size of lesion post treatment, and it's an excellent tool to follow patients on anti-Vegf therapy. All the well-defined patterns demonstrate good reduction, whereas the ill-defined membranes on Opta may not show a good outcome. So identifying the pattern on Opta will help us to understand whether you would end up with a good outcome or a poor outcome. Some of the patterns, like the fishnet pattern that we described, seems to be resistant to anti-Vegf therapy. Now in PCVs, Opta, however, is not very useful in PCVs. It is useful in PCVs in the sense it can pick up the branch and the BVNs very clearly, but in terms of identifying the polyps, this is the ICGA, where you can see this is the polyps. It is very poor in identifying the polyps. So that has to be kept in mind when you apply Opta in patients with PCV. Now coming to the fag end of the talk, now having gone through all the various pathologies and where anti-Vegf could be useful and the regimens, we also need to understand that the cost of therapy is an important issue, especially in our country. Affordability is a big issue. Affordability begets compliance. If you don't have compliance, then the whole exercise fails. You end up with poor visual outcomes if the patient has got poor compliance, whatever be the strategy that you apply. So, as we know, world over, the commonest drug anti-VEGF agent which is used is Avastin. This is a little old survey, the 2018 survey. But again, in the United States, what it shows is Avastin remains the most common drug because of the cost. Again, in the Indian scenario, almost 50% of the anti-VEGF practice mostly involves Avastin. One important issue with the continuous anti-VEGF therapy is the development of RP atrophy, and this is something that we really don't really look for in our patients. And this is clearly addressed by the CAT trial. The CAT trial showed that more the number of injections, more the atrophy, more dry the macula, more the atrophy, and they also showed that ranibizumab causes more atrophy than Avastin because it causes more drying. So this has to be kept in mind when you put patients on long-term anti-VEGF therapy. However, we also have the Harvard study which gave us a different analysis. They said that the monthly dosing did not matter at all. But when you have baseline features like atrophy or atrophy in the fellow eye, or patients with intraretinal fluid are more prone to develop macular atrophy. So in practice, what I do is I look for the other eye if there are signs of geographic atrophy, or if I'm dealing with a geographic atrophy in patient with CNVM, or if I'm dealing with a retinal pseudodrusense, or if there is a type 3 neovascularization that I'm treating, or in a drusenoid PD. These are the eyes where I expect more atrophy. And these are eyes where I would probably think of a fewer injection strategy or a less drying agent. But the other question is, are we seeing as much atrophy as is reported in the trials? In practice, we don't seem to see as much. So that also has to be kept in mind. This is one final patient. This patient presented us with a small occult activity, with a metamorphopsia, and at this point of time, we actually advised a loading dose of anti-VEGF therapy. He was lost to follow. He came back to us after 2 years with a drop in visual acuity, 660. He had already received 6 Avastin, 3 Lucentis, and the situation was 6 weeks after Lucentis. And what we see is a large diffuse PED with SHRM, the intraretinal fluid, subretinal fluid, very active neovascular complex. ICG revealed the presence of the typical polyps in the branching vascular network, and we did a PDT to this patient along with racimab, 2 racimabs, and this is the patient after the racimab maintaining reasonable visual acuity, 636. No further injections this patient required. So in these situations, these are certain situations, especially PCVs, where a combination therapy is a good option. But the question is, does the anti-VEGF agent matter? If you're doing PDT, does it really matter what anti-VEGF agent you give? We do not have a clear answer for that, because the only data that we have is the Everest study, where they have combined PDT with ranibizumab, Eylea. The Planet study did not find the combination therapy to be promising, and we do not have any major studies on Avastin with PDT. So this has to be kept in mind whenever we plan a combination therapy. With regard to safety, Avastin endophthalmitis is something that we are worried of due to spurious and preparation issues. But in terms of arterial thromboembolic events, all these drugs have similar profile. So there's no real major difference between the drugs. Now, long-term therapy. This is something that we have to keep in mind when we put patients on anti-VEGF therapy. If you look at the long-term studies, if you look at the 7-up study where patients were followed up to 7 years, what they showed is that only 43% remained stable or improved at the end of 7 years. That means all the other patients were still losing vision. So that is something that we need to keep in mind. Whatever be the regimen that you put the patients on. The VIEW study showed the 4-year data. If you look at it, 68% were still active at 4 years. If you look at the CAT study again, the gain that happened at 2 years was lost at 5 years. So these patients many of these patients require long-term therapy, and they still, in spite of the best efforts, continue to lose vision. So to conclude, this is a rough scheme of things. This is how I would choose an anti-VEGF therapy. The agent, when I'm dealing with PCV or resistant CNVM or a or a CNVM with a large PEDs, I would tend to think of using ILIA primarily in patients with partial scar in secondary CNVMs whenever affordability is an issue. And when I think that there is a risk of atrophy, I would actually tend to use Avastin. In all other situations, in my hands, Lucentis seems to be the drug of choice, especially when there is a scope of combination therapy. So what I feel that more than the drug, the strategy matters. You need to talk to the patient and convince the patient that that they require long-term therapy, and the strategy, the timing of injection and compliance is something which is very important. So to conclude, optimizing anti-VEGF outcomes in CNVM actually means choosing the right strategy and drug for the right eye, carefully looking at the imaging biomarkers, sustaining a relatively fluid-free retina is crucial, and understanding patient needs and ensuring compliance. It is a long haul and our fight continues. Thank you.
Thank you, Manoj, for that. I think this was one of the excellent presentation I've heard in all these so many webinars we have been having, in the last few months that has been happening. It really clearly shows how much of effort you have taken to do so much of analysis. When people are groping up with so many different types of CNVMs and then the choice of different drugs, you've done an excellent, literature review to do the analysis. And when you said it is your interpretation, but I think it's one of the best I've heard. Thank you for sharing this. We really appreciate the clarity with which you made this presentation. So I'm going to ask our young Dr. Karthik Kumar to moderate this session. We have a few questions from the other audience. So Karthik will be moderating this.
Thank you, Kim sir. That was an excellent presentation, Manoj sir. There are lots of questions. People are really interested in this talk, and many questions are actually flowing in. I think for want of time, we'll ask you a few questions related to this. First, I have a question now. What do you tell a patient when he comes and asks you how many injections are required? This is a very tough question which we face every time. So we tell the patient that he has CNVM. So the next question is how many injections are required? So how do you tell the natural history to the patient? Like,
so
in your clinic, how do you go about it?
That's a very good question. So that's something that now we face day in and day out. So I think the first thing, what I do in my practice is I tell them that that I talk to them about the loading dose. I tell them that you probably require 3 injections at monthly intervals, and at the end of 3 injections, when we reassess you, we will probably be able to give you a better picture. Because if you look at the trial data and and most of our own experiences, if a patient has done well after 3 loading doses, then it is likely that's what the CAT trial also showed. The CAT trial also showed the same thing. Even in a PRN schedule, they showed that if patients have done well after 3 loading doses, it is likely that these patients would continue to do well beyond that. So having said that, we also have to ensure that patients' the compliance is better. So therefore, we need to understand what their finances are at least at some point of time. Even at the point after the loading dose, I would actually, our counselor does spend some time with the patient to understand if he is ready for a long course of treatment. Should you really put him on a PRN? Can he really come to us on a monthly basis or at least 2 monthly basis, or should you be putting him onto a regimen like straight and extend? So I think these are the 2 things. Understanding whether he can be compliant and how he would do well after the loading dose. That will actually help me to give him a rough idea about the duration of treatment.
Thank you, sir. Another participant, Dr. Satya, wants to ask, what is the maximum effect of anti-VEGF agent? Within how many days you see the maximum effect after injection? And if you feel that the CNM is going to be really aggressive, do you want to repeat it within 1 month? So any thoughts on that?
No, if you have to look at the trial data, so there are a lot of case reports, small series which have looked at treating them early. But then if you have to look at the trial reports, we do not have enough proof for that. So as of now, I think trying to give an injection before 4 weeks is something something that is not well established. Now, even we know that now people have even tried. There are also trials which have used 2 milligram of ranibizumab, and now they've shown that even a higher dose does not really matter. So at this point of time, until we have enough evidence, I think we should stick to this 4-week intervals, because we are not very sure about other untoward events also. So keeping that in mind, I think we should still stick on to 4-weekly intervals.
Thank you, sir. And Dr. Chitranjan wants to ask, sir, do you routinely use OCTA, different OCTA, CNV morphologies to your treatment? For advising the treatment, injection basically. Do you like, for example, you told that fishnet pattern. If you feel fishnet pattern is going to be there, you are going to advise aflibercept, or do you routinely make use of the types of CNVM on OCTA for your or say decision making on the type of injection?
Yeah, in non-PCV entities, that is a typical AMDs, definitely, because now I think we are slightly moving away from doing a primary angiography. So if clinically we think it is not a PCV patient based on OCT characteristics, we would just do an OCTA, and we are not doing FA and ICG like before. So therefore, looking at the OCTA is useful. And what we have learned over the last 1 or 2 years is that looking at the patterns, if you have a well-defined pattern, then these eyes seem to respond better than the ill-defined patterns. That is something that we picked up. And among the ill-defined patterns, one pattern, the fishnet pattern, does not have a feeder vessel. It does not. It not like, unlike the sea fan, it does not even have a feeder vessel at the edge. It is just a network of vessels. So these eyes seem to do badly. So I think we can. There's not enough evidence, just because of our observation, we cannot make it a blanket rule. But in practice, we use that as a guide to tell patients that, from our experience, these patients, they are not. This is likely to do well, or this is not likely to do
well. So one more question from Dr. Meenakshi Kolru. She wants to ask that. Yeah. Oh, okay. Sorry. Dr. Kesim sir wants to ask that whether should we always keep the retina dry and treat aggressively with more injections? So, our goal is to keep the retina dry. That is the final. What do you say? That should be the final outcome, or what is your take on that, sir?
No, I think the one it's a very difficult question to answer, because now that the fluid study has said that you could tolerate amount of fluid, but I'm a little skeptical about that. In practice, no, I wouldn't allow 200 micron of fluid. I wouldn't believe that. I'd be aggressive in treating intraretinal fluid. Definitely, yes. My viewpoint has changed about subretinal fluid. I would tolerate a bit of subretinal fluid, but I think I use not just the OCT criteria. I would use the vision criteria along with it. If the patient is remaining stable or 2 or 3 visits, fairly good compliance, then I could actually leave a bit of fluid. But if the patient is not going to come for good follow-ups, I'm not sure whether he would miss follow-up and end up with a fall in visual acuities. In such patients, I would be a little more aggressive. So my aggressiveness depends on the compliance. And also, it depends on what is the type of fluid that I deal
with. One more question from Dr. Piyush Kohli here. Sir, in case of what we call predominantly scarred CNVM, that is the macula is all, the fovea is scarred, but still we have some activity in the parafoveal region. Do we still treat the patient? We know that the visual acuity is not going to improve even after treatment, but is there a role of this treating this CNVM? Probably we can prevent some field loss, so probably it might help the patient.
Exactly.
Anyhow, we are not going to improve the vision. So do we treat those patients?
No, I think I do treat them. I do, in practice, I do treat them, because we see often patients with treated elsewhere or not treated by somebody else, scarred CNVM, and some activity in the paramacular region is important in these patients. They even though on the Snellen chart you don't pick up a visual improvement, they actually feel that the quality of vision has definitely improved. So it really makes sense to treat these patients, but I wouldn't put them on a regimen. I wouldn't put them on monthly injections. I would go on a loose PRN. I call them a loose PRN. I would see patients on and off, go by their symptoms. We could go by their symptoms in these patients, and then look at the visual acuity and then treat. So I do treat patients with scar CNV.
Sir, I think last question. Sir, what about peripapillary CNVM? Are they a part of neovascular AMD, or how do you go about treating peripapillary CNVM?
Peripapillary CNVM, I don't know whether it merits a separate way of managing. But one thing, if I see a peripapillary network, I would definitely rule out PCV. That is something that I would definitely rule out. But otherwise, I think I would manage it just like just like any other coronal neovascular membrane. I don't think that it merits a different way of managing.
Thank you so much, sir. Thank you for your excellent talk. And of course, our lot of questions are still there. I think your talk answered almost all the questions. Now, over to Naresh sir and Kim sir for the final words.
Thank you, Dr. Manoj. This is what I was telling in the introduction also, actually. So now after listening to them, I don't think, because he was telling that we are talking too much about in the introduction. Now, after listening to the talk, people will realize, no, it's not too much of an introduction. It's a very ideal and optimal introduction. Once again, thank you for such a wonderful talk, actually, because none of us were sleeping here, at least for the last 1 hour. So that itself shows how interesting it was. And when we see the quality of the slide, we were very happy in the sense the amount of effort, I mean, the effort you have taken to make the slide. It's not that easy to make a slide of such a wonderful quality. That shows that how seriously you have taken this webinar. We again, on behalf of Arvidaya Hospital Retina, we would like to thank you for giving us such a wonderful opportunity. And we have got a personal request in this, which I think we will mail it or WhatsApp, because we want to listen to this again in one of our Saturday classes in the morning, so that it is telecast to almost all our people, actually. So I once again thank you for accepting this invitation and delivering such a wonderful lecture. One small hitch is like we couldn't download your certificate to show it on the screen. So we'd like to present you a virtual certificate, which will be sending it to you by mail, and the printed one by courier. Thank you, Manoj. Thank you very much.
Thank you, Dr. Naresh. I think it is a great honor, and I think all those words are quite unnecessary, is what I feel. I would like to be remembered as Kim sir's student, and as I'm still part of Arvind. I would never say that my heart is still not left Arvind. I still try to maintain contact with most of my teachers. And it is. I think it has changed my life a lot. I didn't say it, but then when I had some personal health issues, and when I was going through a bad patch, I think the time I spent with Chief, I think that a lot of that came to my mind, and it actually helped me through those bad times. So I'm extremely privileged. I'm honored to actually honored to have to be able to sit and talk in front of you. And I thoroughly enjoyed making this presentation. It was a learning experience for me, and I hope other people have found it useful. Thank you, sir. Thank you, sir. Thank you for inviting me.
Excellent. We really feel privileged to have listened to you.